All right, why don't we go ahead and get started? It looks like most people have come in and gotten their pizza. So welcome to everybody in the room and welcome to folks online. I am really thrilled to introduce our guest speaker for this month's Rollins Grand Rounds. Dr. Brendan Saloner is a Bloomberg Professor of American Health at the Johns Hopkins Bloomberg School of Public Health, where he is in the Department of Health Policy and Management, but proudly also jointly appointed in the Department of Mental Health, which was the past department that I was affiliated with. So I have known him for many years and his work for many years, but I'm going to share with you just a little bit about his work and some of his accomplishments, but they will become self-obvious as he starts speaking. Dr. Saloner has a lot of leadership roles at Hopkins. I don't think I will do justice to list them all, but he co-leads the area of the Bloomberg Health Initiative, American Health Initiative. I want to call it BAHI, and I'm not supposed to, of the Bloomberg American Health Initiative on addiction and overdose. They have done many things out in the practice world as well as the research world, and currently are still actively engaged in an opioid overdose prevention initiative that you may or may not, I don't know, speak about today, but you can ask him about. And he heads their PhD program and is also a leader of the Center for Mental Health and Addiction Policy there, as well as the Berman Institute for Bioethics. And to speak to some of those areas in terms of his recognition nationally, he was an Emerging Leader Award winner, I forgot the name, the Alice S. Hirsch Award at Academy Health, and then also the inaugural Greenwood Fellow in Bioethics of the National Academy of Medicine. We are lucky as a field to have someone of Brendan's accomplishments and passion really advocating for policies and safety nets for people in underserved communities, particularly people who use drugs. And so thank you so much for being here and sharing your work with us today.
Well, thank you so much for that incredibly generous introduction. One of the amazing things about starting a career at Hopkins is just the excellence of the colleagues that I've had to work with. And Dean Fallon was one of those colleagues who we sorely missed, but I'm so excited to see what you're doing here. And so pleased to be back. The last time I was here was in 2016. Feels like I haven't totally left. I was here in March, and it's just great to be back in Georgia with you all. This is going to be a slightly autobiographical presentation, and as I was telling my dinner group last night, kind of the arc of my career is that I started off at 30,000 feet and I've been losing elevation. So I've been trying to get a little bit closer, but I'll never be sort of at 0 feet. So going to tell you a little bit about the work that we do from 10,000 feet. And I tried to pick a title for my talk that sort of conveys the mix of genuine optimism that I feel around this challenge, as well as the pessimism that I feel because we're not making as much progress, and frankly, the numbers are not looking as they're looking quite bad, as you'll see in a minute. So just to give you a little bit of a roadmap of where I'm going, I'm going to just start with a little bit of level setting about the overdose crisis, and then I'm going to talk to you about what I'm going to call touch points around 3 distinct areas: specialty drug treatment, hospitals and emergency medical services, and jails and prisons. And I think it'll be evident why I'm interested in those settings. And then I'll try to just conclude with some directions for research and policy. I know we have some folks joining on Zoom, and welcome to them. And if you have questions, please put them in the chat. I think the chat is being monitored. And if you in the audience have any questions for me, you don't have to wait till the end of the talk. I'm more than happy to take questions as they come, and we can just make this a little more informal and conversational. So with that, let me get started. Many of you know these numbers. This shows the national annual drug overdose deaths. As you can see, if you were looking at this issue around 2017, 2018, there was a little bit of a glimmer of progress. We saw 1 year in which overdose deaths went down. And then during the pandemic, they shot right up. And I think we're going to see some data from the CDC maybe this week that will kind of show that what has happened in the last year is deaths have stabilized, but they are not going down. Or if they're going down by just a very small amount. We're at historically high rates of drug overdose right now. We all come to this issue through our own personal stories and experiences, the people that we know. And I think it's important to just center in this conversation the more than 1 million lives that were lost over the last 2 decades. So it has been I think it's one thing to think about the grim statistics, but seeing the individual faces and knowing the individual stories, I think just speaks to the immensity of this challenge and the importance of not giving up. So when we talk about the overdose crisis, we're actually talking about a crisis that has unfolded in waves. And each of the prior waves has not totally receded. So we actually have this sort of dynamic where there are stacked waves of the overdose crisis. The first one, which got a lot of national attention, was the crisis related to prescription opioids. What you can see is that the original curve that I showed you in black is still at the top. And then shown in kind of a beige color are deaths from prescription opioids. They peaked around 2010 or 2011, but they've remained kind of persistently high. And then that was quickly succeeded by overdose crisis related to heroin, right? So heroin became much cheaper and kind of saturated a lot of American cities. And then that was quickly succeeded by the fentanyl crisis, which we're still living through, shown in red, and you can see the fentanyl line. And then what's really distinct about the moment that we're in now is we're in a polydrug overdose crisis. So many drug overdoses now involve fentanyl in combination with a stimulant, either cocaine or methamphetamine. So I'm going to use this term touch points in my presentation today, and I just want to define it. So I take the concept from the work of people like Mark LaRochelle and others, who define a touch point as an opportunity to identify individuals at high risk of opioid overdose deaths in order to engage them in harm reduction and or treatment. Okay, so in their work, where they've used a linked data registry in Massachusetts, they can find, for example, that more than half of all people who die of overdose had systems contact with an opioid prescriber. That was a very common one. With specialty treatment, so having been admitted to an outpatient or residential drug treatment program, a hospital, or a jail or prison. And I'm very interested in those same touch points. One thing to know about touch points is that you can kind of think about them broadly in 2 ways. So there's some touch points that are relatively common, for which just having that touch point is associated with a slight elevation of risk. So like about half of all American adults have had an opioid prescription in their life. That touch point in and of itself is not associated with especially high risk, but the intensity of exposure with that touch point can increase the likelihood of having the high risk event, which in this case is a fatal overdose. And then there's certain touch points that are relatively uncommon, but having that touch point is really a signal that you are a person who has very high risk. So being released from a carceral facility is an example of a touch point that has been associated with profound risk of overdose death, especially in the period right after release. This is just showing kind of similar data from a project that our team did. So in our study, what we did is we worked with the Maryland Department of Health. We linked basically 6 data systems in the state that covered 3 million people in the state of Maryland, and we looked at risk factors for fatal overdose over a 2-year period. And these are just odds ratios showing you risk of fatal overdose if you've had any of these touch points. So you can see that at the very top is release from prison in Maryland, very high risk of overdose, but also other forms of criminal legal contact, like being on parole or probation or having experienced arrest increase your odds of fatally overdosing. Participating in drug treatment in and of itself should reduce your risk of overdose death, right? But that is a high risk population. So people who have been in treatment have a very high risk of dying of an overdose. And then again, like I was saying, having an opioid prescription in and of itself is a modest increaser of risk, but having 4 or more opioid prescriptions we found was a very high risk population. And people who survive overdose and are treated in the hospital are very at risk of subsequently dying of overdose. Any questions about that? Don't be shy. Yeah.
Is that fatal overdose within their lifetime or during a period of time?
You know, I should have been clear about this. So the question for those of you on Zoom is that fatal overdose over their lifetime or in what time period? And the answer is it's people who we followed in a baseline year, and then we watched what happened over a 12-month period. Did I see another half hand?
I was just curious as to why there is a double, I guess, outfitted for people who are participants. What are the factors playing?
The question is, what are some of the factors related to overdose risk during release from prison? And I'm going to actually come back to that and talk about it at the end of my talk. But let's hold on that question. It's a really good one. Okay. So I'm also going to talk about medications for opioid use disorder as being sort of one of the key interventions that reduces overdose risk. Some of you already know a lot about this topic, but for those of you who don't, there are 3 medications that are approved by the FDA for treatment of opioid use disorder: methadone, buprenorphine, and naltrexone. The National Academies put out a consensus report in 2019 with the title "Medications for Opioid Use Disorder Saves Lives." I think that was good of them to be so direct and explicit, because I think it really conveys the life-saving potential of medications, particularly methadone and buprenorphine, cut overdose risk in more than half. Compared to having treatment without medication. So they really do have this life-saving potential. And the key thing for my present purposes is that choice really matters. So each medication works for some people, but the key thing is that medications work differently for different people, and different people have reasons why they might, for example, want methadone over buprenorphine. So given that this is a really effective intervention for reducing overdose risk, why is it the case that probably far less than half of all people with opioid use disorder use medication in their treatment? Well, there's a few reasons. We have controlled substance regulations. So methadone and buprenorphine in particular are highly regulated by the Drug Enforcement Administration. So methadone can only be administered out of specialty clinics called opioid treatment programs. That greatly reduces the potential places where patients can access methadone. There's financing barriers, so making sure that there's reimbursement to prescribers, that patients themselves can afford the medications. And then there's more subtle issues related to financing, like practices that health insurers have that might impose prior authorization or dosage limits on patients, which also can disrupt their access to medication. Systems fragmentation, which I'm going to talk more about, but basically the idea that many of these folks engage with different systems that are not well integrated with each other, and the fact that those systems are not well integrated disrupts their care. So a good example that I'll come back to is the fact that people often leave the custody of a Department of Corrections where they got all their health care from a correctional healthcare provider, and then they go back into the community and they are now using an insurance card, if they have their insurance card, if they live in a state that has in fact expanded Medicaid, which Georgia has not. So all of those things can kind of disrupt patients' access to services. And then stigma against medications itself, including a pervasive narrative that using medication is substituting one addiction for another. That is something that is commonly said, even though it does not reflect the reality of how medications work for patients. Any comments, questions? Okay, so I'm now going to transition to talk about one area where my team and I have been doing a lot of work on this topic, which is access to MOUD and specialty care. And I'm just going to call medications for opioid use disorder MOUD. So you'll hear that from me a lot. So let's start with residential treatment. So what is residential treatment? Basically, if you think about the different places where patients can get treated for a substance use disorder, they range from fairly low acuity outpatient settings all the way to settings that look a lot like a hospital. And sort of at the more acute end of the spectrum are residential treatment programs, which are intended to be short-term, highly medically monitored settings where patients can get care, especially if they have a lot of acuity or complexity in their case, or they might have a co-occurring mental health and substance use condition that requires sort of intensive management. Paradoxically, residential programs are often one of the least regulated settings of care. And our team has done some work to sort of quantify some of the challenges with providing patients with access to MOUD at residential facilities, which is really one of those places where you absolutely want to make sure patients can get access to medications. So for example, I was involved in an audit study where we had a research assistant posing as a patient who is seeking admission to a program, call up a representative sample of programs and ask them, I'd like to come to your program, but I want to know, can I have medication? What that person was told was that only 29% of the time was she actually offered the opportunity to have medication. And that's actually an overstatement, because many of the times that she was told, yes, you can have medication, she was strongly discouraged by the person on the other end of the line from seeking it. We also found that that whether or not the facility that she was calling had accreditation from the major accreditation bodies like the Joint Commission or CARF, actually had no correlation with whether or not she was able to get medication. So I mean, I think that's a strong signal that whatever we're hoping for from accreditation, which is supposed to be a marker for people who are shopping for care, that this is a high quality treatment program, it's sort of failing in this critical regard. The other thing, which was sort of another discouraging aspect of this, is that there was a lot of very unethical practices from programs that the person called. A lot of inducements to come to the program for non-clinical reasons, a lot of financial predation, attempts to sort of get that person to basically go to their family and get a lot of money that they might not have had to pay for treatment, which probably would not have been treatment that would be very effective. So I think this has raised for me the question of, well, what can we do from a policy perspective? What policy interventions would actually be effective at increasing access to medications in residential facilities? Which brings me to Louisiana. So Louisiana is an interesting case study. So it's one of these states that exemplifies many of the challenges in residential treatment, but also a lot of the opportunities. So for those of you who don't know Louisiana, it's the state that has the highest percentage of their Medicaid beneficiaries who receive SUD treatment going to residential programs. So it's a state that has historically had a high reliance on residential facilities as a setting of care. It's also a state that is profoundly experienced in our overdose crisis. Recent data would suggest that they're about fourth in the nation in their overdose death rate, and it's rising rapidly. Louisiana did expand Medicaid. They did so in 2016. And then they recently received what's called a Section 1115 Institutions of Mental Disease waiver that has allowed them to start getting reimbursed for residential services from Medicaid. And then as part of that waiver, they also agreed for the first time to start offering Medicaid, to start offering methadone as one of their services in Medicaid. They were one of the 10 to 12 states that had been resistant to providing methadone coverage through Medicaid. The interesting thing about Louisiana is that in 2019, they passed a law that was implemented starting in January 2021 that required all residential facilities to provide access to at least 2 forms of MOUD. So they went further than any other state in actually mandating that residential facilities had to offer medication. How this came about is a very interesting case story, which I'm happy to come back to if people have questions about it. Any questions? Okay, so I'm going to share with you some results from a study that was published in Health Affairs in January, as led by one of my postdocs, Olivia Sugarman. And I'm going to do it in 2 ways. I'm going to start by showing you trends for MOUD use in outpatient treatment, and then I'm going to show you what the story was in residential treatment. So let's start with outpatient treatment. So this graph shows you the time trend for the percentage of patients who were treated in outpatient settings who received treatment with MOUD. And any MOUD line is the green line shown at the top. And then we disaggregate that to show you the proportions that were treated with buprenorphine, methadone, and naltrexone. So there's a few things I want to draw your attention to. The first is just the overall growth in the use of any MOUD. So you can see that it went in January 2018 from about just over 20% of all people in outpatient settings to almost 50% by the end of 2021. So almost a doubling in the use of MOUD in outpatient settings over a 4-year period, which is really remarkable progress. Still a long way to go, but showing a lot of improvement. What you can see when you look at the sort of breakdown by medication is that especially in the early 2 years, most of the green line was explained by buprenorphine. And then what you see is that once the state turned on methadone coverage, that there was a big initial spike in the number of people who used methadone in outpatient settings, and that's shown in the blue line. Naltrexone, which is a harder medication to start patients on, many patients don't want to be on naltrexone, even though some do, and we can talk about why. That is the orange line shown at the bottom, stayed pretty flat throughout. Any questions so far? Yeah, David?
Yeah, did the law requiring facilities medication did it affect facilities
Yeah, we haven't looked at that empirically, and it's so for those of you on Zoom, the question is, did the law with the requirement on residential programs, did that cause any of them to exit the market? And I have not looked at that. They could have exited the Medicaid market without exiting the market completely, but Medicaid is an important source of revenue for them. Anecdotally, I'll tell you kind of what the shift was, and we can kind of come back to that question. But yeah, we haven't exactly looked at facilities that have exited the market. That has been the concern. So now I'm going to show you the same trend plots, but this time just among patients in residential treatment facilities. And what you can see is that the monthly trends go from just under 10% to higher than 40%. So as impressive as the gains were in outpatient treatment, they were even more impressive in residential facilities. You can see when the phase-in of Act 425 was in January 2021, it actually does not, to the eye, look like much changed right after that. But what we have learned from talking to the state is that the state was doing a lot of technical assistance in the lead up to this law. So the state agency that was sort of tasked with making sure that facilities were in compliance was doing a good amount of outreach to try to bring them into compliance leading up to the law. And I think that probably explains why things started going up in 2019. The other thing you can see is that there are some different dynamics in the types of medications used in residential programs than in outpatient. So much greater reliance on buprenorphine and naltrexone, which actually was the leading medication used in the beginning of the study period. And methadone is almost flat. Very unlikely that patients in residential programs get methadone. And that has a lot to do with the fact that methadone for patients who are in residential programs, either you have to take that person and bring them to a methadone clinic, or you have to go to a methadone clinic and bring the medication to that person. So there's a lot of operational barriers to getting patients on methadone. Any questions? So our team was also interested in looking at this at sort of what happens with residential treatment in a more dynamic way. So now I'm going to share with you some results from a working paper. And what I'm displaying here for you is the black line is showing you the percentage of patients per week, so that the unit of analysis is different than in the previous slide, who were receiving any MOUD, that's the black line, and the red line is showing you the incidence of overdoses in the 20 weeks prior to admission to residential treatment. So I'm just trying to make sure you guys all get the setup. So week 0 is the week of admission to residential treatment. And then I'll show you what happens in the 20 weeks subsequent to that. So you can see that leading up to an admission to residential treatment, it's pretty flat in terms of use of any MOUD. And you can see that there's a slight uptick in overdose right before admission to residential treatment, which makes sense because often that is the precipitating event that gets someone to go to a residential program. And then I'm going to also show you that same breakdown by specific types of medication. So the black line, again, is going to be any MOUD, but I'll also show you the trends for buprenorphine, naltrexone, and methadone separately. And you can see that most of these folks, before their admission, were either using methadone or buprenorphine before residential admission. Questions? Okay, so let's see what happens after admission to residential treatment. So actually, we were really surprised by this. This is one of those instances where genuinely the hypothesis I had was not borne out by the data, in that we had expected to see that admission to residential treatment would be associated with overall a reduction in medication use. In fact, what we see is that in the immediate aftermath of a residential admission, that black line sharply increases. So there is this one-time sort of big jump in use of medication, and then you can kind of see it starting to taper down. And most of that jump up is explained by the blue line, and to some extent the purple line. So the blue line is use of buprenorphine, and the purple line is use of naltrexone, which is often given as just a 30-day shot. And that the methadone line, shown in orange, follows a different trajectory. So that one dips down, and then it only starts to sort of slowly recover in the 20 weeks after a residential admission. So basically, the story that this is consistent with is that residential treatment does increase medication use over a short period of time, but that is not totally sustained, and that the only medication that residential admission seems to cut off is use of methadone, which, again, fits that picture that residential programs are not particularly good at getting their folks into methadone clinics. They're better at figuring out how to get their patients onto buprenorphine, at least over a short period of time. Any questions about this? Yeah. So the question is, how long is a residential stay? The lengths of stay vary. Often they're 14 to 28 days, and that sort of conforms to how insurance pays for residential treatment. So some of this is weeks in which somebody was physically in a residential program, but much of it is spanning a time period after release from a residential program. Was there another hand? Yes.
I'm just wondering if you could comment on the fact that naltrexone is going up right beforehand. Is this people not realizing once you're on naltrexone that you're not going to feel any effect from the medication, or is that just such a small blip that it's not really relevant? And does the yellow line represent people who, for whatever reason, were falling off methadone, and once they went into a residential facility, they found that there were some other agents that might be easier to access?
Yeah, so the question is about the specific dynamics around naltrexone, which might be slightly going up before residential admission. I think it's hard to say, and we haven't done a trend test on that. And then methadone, which seems to be decreasing right before residential admission. Part of what I think is going on, but this is just my speculation, is that some of these people are in crisis right before. So some of them may actually be in the hospital before, in weeks -2, -1. So they may not be getting methadone as reliably in those settings. I think the naltrexone story is pretty consistent with a lot of residential programs giving them a Vivitrol shot, which is the 30 days, and then those folks not coming back and getting a second shot, which is often what we see. You have to be fully abstinent to start Vivitrol, and then you have to sort of present and get a second shot, and a lot of people don't tolerate it or like it very much. Yes?
Are these people in their first residential admission, or could some of them have been readmitted? Do we know kind of who is in that regard?
Yeah, the question is, are these folks all in their first residential admission? And we did not make that a requirement. The only requirement is that they not have been admitted to residential treatment in this 20-week preceding period. But we do know that some people cycle in and out of residential facilities. Yes.
There's a question online. Were there structures post-discharge that improved outcomes in the later weeks, like case management, peer support, and types of follow-up?
So the question online is about structures that might have been present in the weeks post-discharge, like case management and that kind of thing. And I'm going to actually talk about what might be going on in just a minute. So what what we do here is also take a look at these data from the perspective of a facility. So this is a bubble plot. Each of the bubbles is sort of scaled to the number of patients that are treated at those facilities. So take program A shown here. What you can see on the x-axis is the percentage of patients who went to that facility that were getting MOUD prior to admission to that facility. And then on the y-axis is the percentage of patients at that same facility that got MOUD post-admission, right? So at program A, which is one of the bigger ones in the state, just over 20% of their patients had been getting medication pre-admission. And then in the period after admission, about 60% had any MOUD. It was like, I'm not saying how long they were on medication, just do we observe them getting any medication? And kind of every facility that was large enough to look at in the state, so they had to have, I think, a minimum of 100 admissions during the time period, we did the same thing for. And then just the dotted line is representing kind of the slope that fits through that scatter plot. I just want to point out that the 45-degree line would represent a point of equality, right? So if patients had the same rates pre and post, they would all sort of fall somewhere along the 45-degree line. The fact that the line is tilted upward is consistent with this idea that on average, patients are using more medication after their admission to a residential facility than before. But the other thing that I really want you to take away from this slide is the vast amount of spread, right? We have some facilities that are performing quite well toward the top, and then a big clustering of facilities toward the bottom that are having very low rates, both pre and post. And why is that? I mean, we can kind of tell some stories, but we are still trying to sort of investigate what might be present or absent in those lower percentage facilities. So I think to the question that I just got on Zoom, I think it probably speaks to some elements, not only of the facility, but of the community that the facility is in, right? Louisiana is a state that has some large urban areas, but also quite a lot of rural communities that may have poor community treatment infrastructure. So I want to explain this slide because what we do here is we do try to model some of this as heterogeneity by facility types, which we bucket into a high, medium, and low group. And those groups just kind of represent what you saw in the last slide. The higher ones are those that had high rates of MOUD use post-discharge. Medium is sort of the ones in the middle, and the lower, the lowest. You can see that patients who are admitted to higher MOUD use facilities do have slightly higher rates pre-admission. We do this is now estimates from interrupted time series models, but the crude coefficients look pretty much like the kind of the modeled coefficients. But what you see is that there's this sort of interesting thing that happens post-discharge where there's a fanning out. So if you are admitted to one of these higher facilities, you start higher and you stay higher. So the blue line doesn't really dip down much. The medium one is on a downward slope, but not as striking as the low facilities. So there's something that's going on that's not just an attribute of the facility, but about sort of the facility plus the community or the sort of continuing care infrastructure in that place that is really kind of probably part of the secret sauce of some of these higher performing facilities. Yeah.
Do you have any evidence, maybe qualitatively, of patients self-selecting into certain types of programs that favor, these patients themselves may be stigmatized against medication and whatever, and maybe more likely to be attracted towards these programs that also prefer.
So the question is about what the evidence might be, qualitative or otherwise, about patient self-selection into facilities. And I'm taking this story much more seriously now than I was when I started this project. I thought that there wasn't going to be as striking a difference between patients who go to residential programs and those that don't. But clearly there's some kind of sorting mechanism that is underlying what happens even before the patient sets foot in the facility. Whether it's the patient's own preference or there's attributes of the community that are sorting them into these facilities, I think it's hard to say. I'm going to show you some qualitative results in a second that are also going to kind of add some complexity to that story. Yeah.
A lot of these state-based facilities are ones with great one.
I've not done so the question is, are they faith-based facilities? And I have not fully broken that down. We do know that there are a number of faith-based organizations that provide residential treatment, that some, but not all of them, have a more sort of oppositional relationship with medication because they may subscribe more to a faith-based model of addiction than more of a biomedical model. But until like we kind of really dig into that story, I don't want to make any strong statements on that. But it's a really great question. Did I see another hand? Yeah.
Can you talk a little bit about why the rates on these weekly graphs are so much lower than on the previous slide, the rate on the bubble plot, right? They were much higher, like 20% pre-admission and then like 40% post. And here we're looking at like 2% pre and maybe 5%. Is that reflecting like patient turnover? Like, right?
Yeah, so the denominators are changing a little bit in these, and it's also that it's to count in the numerator on these, you have to have medication not only in that month but in that week. So that's explaining some of it. But yeah, not being able to do the math totally on the fly, I can't I can't answer your question fully, but it's a good one. All right, so we did a qualitative study. We were asked by Arnold Ventures to study this question about whether it would be beneficial to basically have all states do what Louisiana does, which is impose a requirement on residential facilities. And we got some really interesting quotes from state policymakers. So some of them perceived that there was a trade-off between access to care on the one hand and minimal quality standards on the other. So I'll just read you some quotes. So this state official said, "You're not a social service provider, you are a medical provider. You need to offer appropriate medical care, and that's our expectation when we license you." So definitely subscribing to the idea that this should be required versus the perspective that, well, as we improve quality, we risk losing what limited access to services we have in some regions. So exactly that concern that David raised earlier about facilities exiting the market if the standards imposed on them are too draconian. There's also a perceived split in our respondents between taking more of an education stance versus having more of an enforcement perspective. So this I'm sorry? Oh, okay. We had this quote: "Most of your providers want to keep people safe and have good treatment. Regulatory authorities can get overly punitive and not have a technical assistance focus. And to me, that's really key. If you want to make changes, you don't just declare them. You have to listen to your providers. You have to include them all along the way, even if they're coming with you kicking and screaming." Versus this kind of perspective that I think that the soft approach is nice, but that the only real way sometimes to make change is if it's law, because then when there's a consequence associated with it, it's a lot easier. So kind of giving voice to this idea that you can only really get strong change through requirements. Then we did talk to some programs that were unhappy about being under this requirement, sort of to your comment, Courtney, and they were saying things like, what we're doing is not because we've decided that medication is a bad thing. It's because we're listening to our clients. This is what they want or feel, and this is how we're going to treat them. So sort of a perception from that program that, listen, we will offer medication, but you're seeing low rates from us because our patients don't want this. So kind of figuring out, where do you set a benchmark for programs? Do you all ask them to perform in the same way? Do you allow for some variation? How much should patient choice actually matter? I'm now going to pivot and talk about a different area of research. So let me just see if there's any other questions about specialty treatment. Okay, is everyone having fun?
Quick question. So would you judge that the Louisiana law has been a big success? It looks like there's been a lot of positive outcomes for that. And to what extent has this been adopted in other states?
So the question is, would I judge that Louisiana is successful, and has this been done in other states? And the answer to the second question is not many other states. There are states that go not quite as far as Louisiana. New York State probably comes the closest and has sort of a similar requirement for outpatient, not residential programs. And then states like California have started to say, if you want to get Medi-Cal reimbursement, which is a state Medicaid program, for residential services, your residential program has to offer medication. So they've gone further in that regard, but most states are not pushing the envelope as much as Louisiana did. Do I think it's been successful? I do. I think that I think it's a good example of something that I see a lot in my policy work, which is sometimes laws are set and the people who have to implement that law are kind of grumpy about it, and implementation is tricky and hard. But at the end of the day, it's better that the law is there than that it's not. And I think the devil is always in the details because it has a lot to do with enforcement and capacity. A mandate in and of itself is not effective without having a lot of technical assistance and support for providers. All right, so I'm going to talk about some work on another setting where you would expect medication to be universally available, where it's sorely lacking, which is in hospitals. And then I'll talk about a little bit about emergency medical services. So we know from the pioneering work of Gail D'Onofrio and others that buprenorphine provided in the emergency department is a very effective intervention at both treating symptoms of withdrawal, because patients, especially if they've been revived with naloxone, are often very uncomfortable in the hospital. It is very excruciating to have the physical symptoms of withdrawal, so buprenorphine actually can help manage those symptoms. But also it can put them on the path to starting and staying on medication, which reduces their risk of coming back to the hospital for another overdose. Despite that evidence and many other similar studies, we can see that there's very low adoption of buprenorphine in hospital emergency departments. A few states, and my team has been working in a couple of contexts where states have tried to sort of undergo campaigns to try to incentivize greater adoption of buprenorphine in hospitals, have got these initiatives to try to encourage hospitals to do more of this. So Pennsylvania was a leader in this. They started a program called the Hospital Quality Improvement Program, and basically they paid hospitals a one-time bonus if the hospital just self-attested that they provided certain pathways of treatment for patients with opioid use disorder. The more pathways that they attested to, the more money that they could get, and one of those pathways was providing buprenorphine in the emergency department. And then going along with this was a learning collaborative that the Pennsylvania Hospital and Health System Association kind of launched to try to give the hospitals capacity. So we evaluated the impact of this hospital quality improvement program using Medicaid claims and partnering with a team at Pitt that does a lot of Medicaid research in Pennsylvania. And basically in our models, the exposure variable was whether or not a patient who was treated for an overdose was treated at a hospital that had adopted this pathway versus patients who are not adopted at the pathway. So as a sort of internal to the state, we could find some good comparisons. And we did find, in fact, that this, the implementation of the HQIP program was associated with pretty meaningful increases in the use of buprenorphine. Still over a very low baseline, but we could see that after HQIP implementation, there was a 2.6 percentage point jump, equivalent to about 50% over baseline, in use of buprenorphine in the time period after release from the hospital. And we could also see that that effect increased in the second year of the program's implementation. So it sort of gained a little bit of strength over time. We didn't see any changes in the incidence of overdose, however, and we didn't see any changes in use of other medication or non-medication treatments for opioid use disorder. So it's like a good success if you just looked at the metric of did this policy increase use of buprenorphine. But along with this work, we did some qualitative research to understand how key informants in Pennsylvania felt about this. And they told us some like really interesting things, that some nuance that didn't really kind of get fully conveyed in the quantitative analysis. The pervasiveness of stigma, even among hospital clinicians, both nurses and physicians, is really profound. Statements like, I think the associated with, well, I'm going to give them Suboxone. That's like Narcan, which is the overdose reversal medication. It's just encouraging further use. And fighting that is like being a salmon trying to swim upstream. So this is from one of the champions in a hospital who's getting a lot of pushback from their colleagues. The other thing that we heard a lot about was a lack of comfort or familiarity with the medications. So this person said, not all the doctors in the ED are comfortable with MOUD. We have a couple who said, I'm not touching it with a 10-foot pole. It's not in their wheelhouse, and they're not comfortable with it. So they'll do the warm handoff, so basically engage another clinician or a peer, and then they'll stop short of initiation of the medicine. There were some saying, well, if we only have to do it very rarely, like every 6 months, we'll get rusty at it, we're gonna mess it up. a lot of fear that they would do it wrong, and so they didn't want to do it. Then some quotes actually saying that the HQIP program itself was very important in kind of creating a norm that this had to be done, and that it went up to the C-suite of the hospital. So really like thinking about this not only from the perspective of a financial incentive, but from the culture change that has to result from the incentive, and also really getting clinicians to buy into the idea that this is just part of their job. This is not discretionary. This is not optional. This is another service that you should just offer in the hospital. Any questions? You're doing on time. Oh, shoot. I've only got 10 minutes.
Yes, sir.
Should we talk about jails? All right. I'm going to skip by EMS facilitated buprenorphine, which is an interesting model we tested that gets patients into treatment. And I'm going to talk about jails and prisons. Okay. Here's a short story. Incarceration is a profoundly dangerous event for risk of overdose. We know that jails and prisons could be doing more to treat patients with medications, but there's a lot of challenges with getting medication programs started in carceral facilities. This is just showing you sort of the very uneven map of implementation of this and the low rates of adoption of some of these practices in local jails. Draw attention to a piece that I wrote in the New England Journal on using Medicaid as a potential way to incentivize more treatment in carceral facilities, and a schematic that just shows kind of the multiple different pieces of someone's journey through jail and prison that make it difficult to start medication, whether it's at the start of when they enter a facility and they go through screening, the logistics of dispensing medication, which are really interesting and profound, a requirement of service of staying in a program when you're incarcerated, and then the tricky thing about making sure that services are available during reentry. And yet we know that we're in a period of profound change in carceral facilities. So this is a figure where we looked at just aggregate shipments of buprenorphine into carceral facilities in the US. And we can see that around 2019, the curve just goes up. And so there's been a lot more medication flowing into carceral facilities, even though it is far from being the standard of care. So my team and I are right now in the midst of an R01 from NIDA to study a law in Maryland that requires each of the 24 counties in the state to provide all 3 medications in detention facilities. We're starting with our qualitative portion, so we're doing a lot of site visits and interviews with wardens and security and medical personnel, and also we're finding folks who are incarcerated and doing interviews with them to ask them about their experiences. From our conversations with medical and security leaders, we're hearing a lot about their challenges with funding and staffing, their frustration that the state basically mandated that they do something without providing them with the resources to do it. Huge concerns about diversion of medication, which basically is the idea that they have concerns that when they give patients buprenorphine, that those patients are going to not take the medicine that was given to them, but to try to sell it or give it to another person who's incarcerated. So they have all kinds of elaborate protocols to try to basically prevent that from happening, which I've witnessed. And basically a wait and see attitude. Like they're not thrilled about it, but they also realize that things have to change. And so they are willing to go along with this for now. These are really early findings, but we have some really interesting quotes from some of our conversations with folks who were recently released from jails. Many of them saying that the jail programs are helping. So here, for example, someone says, the difference is that I would have to withdraw everything before while I was in there, and then last time I was there, they passed a law I didn't. Another person saying, you're in jail anyway, so why not? A lot of people can kid themselves and say that they're going to stay clean, their words, and maybe some do, but I know a lot of people that got out, and the very next day they got out of being locked up, they were dead. Then kind of as a counterpoint to that idea that diversion increases, some people felt like actually having medication within the walls cut down on the illicit market. So this person said, it creates a market when they don't offer it. And so people have it in there and they charge crazy, crazy amounts of money. And there's all kinds of fights and it's just insane. And it happens way more than most people would realize. And when you go somewhere where they have it, which is the program, was completely different atmosphere. People saying that this also helped them during their reentry. just give a plug for some of our advocacy work. We're doing a lot of work to try to encourage more carceral facilities to use medication treatment. I'm doing an event next week, which I invite you all to join virtually with the Office of National Drug Control Policy on access to methadone in carceral facilities. And I'm going to just now conclude with a few thoughts about further directions. So this is a mobile treatment vehicle. I took this picture in Portugal. This basically looks like a food truck. It serves about 700 people a day, which is hard to imagine. Here, it's just operating outside of a wastewater treatment plant. And it's the most kind of low threshold medication option you can imagine, because people can just come and go. If they can still be using drugs and use this vehicle. Many of them also get safer use supplies from this vehicle. So this is what this is like my North Star. We are also trying to do mobile units in the US, but it's so cumbersome and difficult to get mobile units started that we couldn't ever have vehicles like this one in Portugal. I'm in a moment where I am posing a lot of questions that I don't know the answer to myself. So I hope you all will help me think about these questions. I'm really interested in what models of care delivery actually work and for whom. Mobile medication units are not going to work for everyone, but some patients may benefit from them. I've become very obsessed with questions of scaling interventions and understanding why is it so difficult to not only start a program, but to offer it with fidelity to a lot of people. And then understanding how much of the problem is really financing versus non-financial barriers. And then finally, just like we want to get more adoption of high-value care, how do we disadopt low-value or questionable care? Those are questions I have. I don't have answers for them, but I really enjoyed being with you all today, and thank you so much for your time and attention. This is a quote I like, that the future is already here. It's just not evenly distributed. And then you can go out in the world and you can be an optimist because you can find models that are working and people that are getting helped. We just need to get those models to scale. Acknowledgements, and then I promise you I'm done. Thank you.
Hopkins, we have a couple minutes.
Yes.
Yeah, if the state like Louisiana or some other state wanted to do to address those final 4 points that you have there, could they do it literally, or are there sufficient or unfortunate federal barriers or other barriers that would limit what a state would do, or how committed it was doing it?
So the question is, how much could a state do given the federal barriers that exist? I think states are just starting this journey, so we don't know how far they can get. The federal barriers are real. So to take the mobile medication unit, the Drug Enforcement Administration and SAMHSA have substantial regulations that constrain what a vehicle could look like and how it would operate. So no state can do a Portuguese, food truck style methadone delivery vehicle. But there's a lot of things that states can do. They can have requirements on jails and prisons. They can have requirements on specialty treatment in jail, and they can do it in hospitals. So there are levers that states have to pull that would make a lot of progress, even with the federal barriers. Yes.
How much of the problem is the financial? I know that was on your slide. Could the buprenorphine be covered by in the 340B pharmacy? How cheap is it in Maryland, for instance, to get the buprenorphine? Is cost a barrier in Medicaid solutions?
Yeah, the question is about the cost barriers in medication. Medication cost itself used to be a big barrier. Methadone costs pennies, so it's really not an expensive medication. Buprenorphine is still patented in some formulations, though it's available as a generic, so cost is going down, but I wouldn't totally minimize that. I don't know enough about the 340B program to give you like a really good answer on that, although I know that that's how some carceral facilities source medication. One thing that I learned about carceral facilities is that one of their main line items on their budget is not medication, it's staffing. So really, it's like figuring out all the non-medication costs that make these programs really difficult to scale.
I'm just thinking, as people get out, is it something that they can continue if they go?
Yeah, and in fact, the new 1115 waiver requires that states provide individuals leaving carceral facilities with 30 days of medication on hand. And in the Philadelphia jail, for example, you can walk out of jail and with a blister pack of 30 days of medication. So we could do that. It costs a little money, but I mean, think about what costs you're also averting by giving people medicine. Okay, I should probably end. I'm happy to take more questions. But...
Yes, let's end on that. I was going to ask you a question, John.
Oh, I'm happy to take your question.
You know, you focused today on all the work in the medication space.
Yeah.
There's a lot of strategies beyond just the medication space to address the overdose epidemic, right? You know, can you just give a flavor of some of the other big areas that maybe not you personally, but the field or others within the American Health Initiative are working?
So the question is about all the other things that are not medication that would be really impactful at reducing overdose. I think that we should center in that harm reduction. So I don't view it as two different oppositional strategies. Some people want medication treatment and they also want to keep using drugs, or they're not ready to be fully abstinent. There's a lot of things we can do to make people safer in their drug use. So overdose prevention sites are the real goal. We have seen that they actually can exist successfully, beneficially. In New York, On Point was sort of the exemplar. But short of that, I mean, you know, access to safer use supplies, fentanyl test strips, and then the other pillars of drug control policy are prevention. So I'm a believer in prevention. It's just not the thing that's going to bring our overdose mortality curves down as quickly, but we have to think about it as a multi-generational strategy.
Thank you so much.
Thank you.